Welcome, everyone, to our third in a series of webinars on fall prevention. This one is focused on implementing best practice exercise interventions for seniors' fall prevention. And we have a great set of panelists today. I will introduce them shortly. But before I begin, I want to acknowledge the land on which Parachute's offices are located. For thousands of years, it has been on the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, Métis, and the Mississaugas of the First Credit Nation. Today, this land still is home to many Indigenous people, and we're grateful to have the privilege and opportunity to work on this land. Today, we're meeting virtually with many of you, and that gives us an opportunity for each of you to reflect on the Indigenous lands that we live on. Today, I'm actually located in Pickering, which is just east of Toronto, and this land has long been taken care of and sustained by several distinct First Nations, the Huron-Wendat, the Anishinaabe, and the Haudenosaunee. Some important information to go over with you today. This webinar is being recorded, so you will receive a link, and anyone who's registered will receive a link. It will live on Parachute's YouTube channel, so it will be available if you wanted to review any of the information. We will have time for questions at the end of the webinar, so please use the Q&A function. Use the chat function. We have great Michael and Stephanie in the background monitoring any issues. If you need any assistance, please use the chat function. And at the end of the webinar, as we always do, we will have a very short 1 to 2 minute evaluation that we ask you to complete. It really does help us with feedback on the content, on what you'd like to see next, and tells us a little bit about how we're doing in terms of these webinars. So please take a moment to complete that. It will automatically come up at the end. And just to recognize that this webinar is part of a larger project that has been funded by the Public Health Agency of Canada. And just to acknowledge that the content of the webinar, though, does not necessarily reflect the views of the Public Health Agency of Canada. So getting on to our fantastic nationally representative panelists that are here today with us. Dr. Marla Beauchamp is a physical therapist and associate professor at the School of Rehabilitation Sciences and an associate member in the Department of Medicine at McMaster University. Dr. Beauchamp holds a Tier 2 Canada Research Chair in Mobility, Aging, and Chronic Disease, and an Early Researcher Award from the Ministry of Colleges and Universities focusing on mobility and technology. The overarching aim of Dr. Beauchamp's research is to identify ways to keep older adults healthy and mobile in their homes and communities for as long as possible. Her ongoing work is funded by CIHR, AgeWell, and the McMaster Institute for Research on Aging. Internationally, she's contributing to mobility measurement initiatives for the WHO's UN Decade of Healthy Aging and leads the Sex and Gender Working Group for the World Falls Guideline Initiative. Our second panelist is Dr. Teresa Liu-Ambrose, and she is a physical therapist and a Tier 1 Canada Research Chair in Healthy Aging at the University of British Columbia, Department of Physical Therapy. She directs the Vancouver General Hospital's Fall Prevention Clinic and co-directs the Center for Aging Smart at VCH. She is a Canadian Academy of Health Sciences Fellow. Teresa leads the Canadian Longitudinal Study on Aging Data Collection Site at UBC and the CLSA Neuroimaging Working Group and co-leads the CLSA Healthy Brains, Healthy Aging Initiative. Dr. Ambrose's research focuses on understanding the role of exercise and other lifestyle interventions on promoting cognitive and mobility outcomes in older adults. Her research findings have been implemented into clinical practice, community programs, and international practice guidelines or recommendations to promote healthy aging and fall prevention. And Dr. Kathryn Sibley is a settler Canadian, and professor in community health sciences and occupational therapy at the University of Manitoba in Winnipeg. Kate holds degrees in kinesiology, rehabilitation, and medical sciences, and a postdoctoral training in knowledge translation. Kate's research aims to optimize fall prevention and rehabilitation services for older adults, and she works with organizations, clinicians, and community partners throughout her work. So we have a stellar lineup of experts on this topic of exercise and fall prevention. So thank you all for joining us today. And I will not delay any longer and ask Dr. Beauchamp, Marla, if you want to put your slides up and start us off.
Okay, can you see my slides?
Yes.
Wonderful. Thank you for having me here today. So I always love talking about fall prevention. It's an area really close to my heart as a physiotherapist, and something that I've seen, the consequences of falls, obviously seen that in clinical practice quite a bit, and now even with aging parents, really appreciating how important this is. So thanks very much for having me. So I get to set the stage for Dr. Liu-Ambrose and Dr. Sibley. So I'll just talk a little bit briefly about the burden of falls, how and why falls happen, some of the evidence for fall prevention, and then sort of just introduce the role of exercise. So burden of falls, and if you're coming to this webinar, you've probably heard this data, but 1 in 3 older adults in Canada fall each year, and that number increases as age increases. So if we go to over the age of 75, we end up with almost 50% of people that will have a fall in a year. And from our own data, looking prospectively and measuring falls every month, we're actually seeing even higher numbers. They have devastating consequences. So 95% of all hip fractures are the result of a fall. And they are really the leading cause of injury-related hospitalization and of death among older adults in Canada. And the really sobering statistic is that when you're admitted to a hospital because of an injury from a fall, you have about 1/3 of people end up going to a long-term care facility after a fall. So these, people that are previously functioning independently in their communities can really, a fall can really change the trajectory of someone's life. And obviously the economic benefit of falls has been well documented almost, and these are a little bit older numbers, but around 6 billion a year in terms of cost. Now the issue is that if we look in Canada or we look globally, falls are actually on the rise. They're increasing, and this is really driven by our rapidly aging population. So this is data from the hospital discharge abstract database. So it's all hospitalizations as a result of a fall from 2008 to about 2020. And we can see there were sort of 47,000 hospitalizations due to a fall in 2008, and that number increased to over 70,000 in 2019. So that's almost a 50% increase in the last decade or so. But if we look on, those are the purple bars, and if we look on top, those are the age standardized rates, the turquoise line, and you can see the age standardized rate has remained relatively constant. So it's not because people are falling more that we're having this rise in falls. It's because our population is aging, and this is the same trend can be seen in multiple countries. So the good news is that this is one of the things we can do a lot about. So if we identify risk factors in our patients, and our clients, we can provide them with tailored interventions, and we can actually reduce both the rate and risk of falls by 25 to 40%. And I cannot impress upon you how large this number actually is. If we think about a statin, which is widely used to treat cholesterol and reduce the risk of heart disease, that can reduce risk by in the order of around 30 to 35%. So this is something that we actually have tools we can use to reduce the risk. So first key message from my talk is, falls with aging are a common and growing problem, but many falls can be prevented. So how and why do falls happen? So first of all, what do we mean by a fall? So the World Health Organization defines a fall as an unexpected event in which an individual comes to rest on the ground, floor, or lower level. And when we look at data, so this is just data from our one of our ongoing cohorts, where we've looked at data, we've collected prospectively capturing falls every single month, and every time someone has a fall, we call them and we find out the circumstances around the fall. So this was data just from the first 12 months of the study, and we had 891 falls reported from 954 older adults. And looking at that data, 56% of falls occurred while standing or walking, 19% occurred on stairs or steps, and we live in Canada, so 9% of falls occurred while walking on ice or snow. But the take-home message here really is that most falls occur because of a loss of balance during standing or walking. And this is really critical to understand, and you'll see we'll talk more about this throughout this webinar. But what do we mean by balance? If most falls occur because of a loss of balance, what do we mean? And balance is actually the ability to maintain center of mass within a base of support. And if we look at this figure here, center of mass is the point. If I'm standing here facing you, it would be around my belly button. So it's at the point of the center of the body's total mass distribution. And base of support refers to the surface, the area of the body, so your feet that are in contact with the support surface. So where your feet are in contact with the floor. So your balance is the ability to keep that center of mass within the base of support. And if we narrow the base of support and we move the center of mass too much, that's when we're at risk of losing our balance. And these are actually slides from Dr. Sibley that I really, really like. So this is a figure of a gymnast that you can see has very, very, very clearly lost her balance. So her center of mass has now shifted well beyond her base of support. And her only recourse in this instance, in order to prevent a fall, is to recover her balance. And you can see muscle tracings. It doesn't matter which muscles, but these are muscles in the legs and in the core that have to come on really, really quickly. So within around 100 milliseconds, these muscles have to come on to help with the balance reaction to avoid a fall. So balance is a really complex skill. It's controlled. It's almost a skill that happens automatically, but it can be trained, and we'll talk about that today. So key message number 2: most falls happen when standing or walking, and balance is really critical to avoid falls. So which risk factors matter most? And so this is kind of one of our active areas of research in our research group. This is data from a systematic review, actually an umbrella review conducted by Dr. Stephanie Saunders, a postdoc in our research group. And she looked at 355 different studies that had looked at risk factors for falls. And we identified which risk factors were the most common. And the first was frailty, the second was balance, third was chronic conditions, fourth, psychosocial factors, for example, social support, mobility was fifth, Six, it was, and oops, we have a double number here. Six was cognition, and then seventh was strength. So we really, these are the factors that have been most studied, and that have been shown to be most consistently associated with fall risks in older people. Now, there's been a lot of research on how do we create tools that identify people accurately that who will fall in the future. And unfortunately, those tools are only have limited accuracy. So really, there are the World Falls Guidelines has actually three key questions within it that do a pretty good job at identifying people at risk of falls. So very simply, you could ask, have you fallen in the past year? Do you feel unsteady when standing or walking? Or do you have worries about falling? And if you have a yes answer to any of these three questions, you have an increased risk of falls. So it's a really, really simple way to screen for risk of falls and to identify people that might need intervention. Now, it's really important to note, however, that even if someone answers no to all these three questions, doesn't mean the risk of falling is nothing. The risk, about 30% of people who will fall in a year will have said no to every single one of these questions. So third key message is the top risk factors for falls are history of a previous fall, chronic conditions, being frail, and having poor balance. So what can you do to prevent falls? So we've talked about already that up to 40% of falls can be preventable. And today we're going to focus on exercise. But there are other interventions that can help. So one is medication review. So having your clients or your patients go to their pharmacist and look at stopping or changing medications that may cause side effects that increase fall risk. So that's a really important one. And modifying the home environment is another really important strategy where we can make sure to remove trip hazards throughout the home, improve lighting, install grab bars in bathrooms. So really, really practical home modifications that can be done to reduce the risk of falling inside the home. And then, of course, vision and feet. So, having vision checked as we get older. Visual acuity can change, depth perception. So making sure that people are going to their annual eye exams and getting their vision corrected as needed. And then proper footwear and sensory checks on our feet can also be really important and can be done with the help of a healthcare provider. But really, from all of these kinds of interventions, exercise is probably the single most consistently effective intervention for preventing falls. And we're going to hear more about this in a minute from Dr. Liu-Ambrose, but in this case, exercise really truly is medicine. And we know that balance, challenging exercises along with functional strengthening can reduce falls by up to 34%. And there's also some evidence that Tai Chi can reduce falls in the order of about 20%. So exercise is truly the most powerful thing we can do to prevent falls. And so I think I will leave it here for Dr. Liu-Ambrose to continue, but just leaving you with the fourth and final key message is that exercise is consistently the most effective single intervention that we can do to prevent falls. So thank you very much.
Thanks, Marla. Some of us are probably disappointed with that last key message, but I think the one of the messages is that these are modifiable, for sure.
Definitely.
Getting some questions in as well, so that's great. Keep them coming. We'll have the Q&A at the end. That's great. All right, so Dr. Liu-Ambrose, do you want to set up your slides?
I'm doing that right now.
Wonderful, thank you.
Okay, just double checking everyone can see my slide.
You are good to go.
Okay. Well, thanks everybody for being here today, and certainly thanks to Parachute for inviting me and also organizing this panel. So just to follow Dr. Beauchamp, I'll be focusing on the role of exercise in preventing falls, and again, just emphasizing among community dwelling older adults. So older adults are still living in their own homes or perhaps assisted living. I also just want to acknowledge that I am at UBC, and so I have the privilege to work on the traditional and the ceded territory of the Musqueam people. And I always like to anchor my talks on learning objectives. So today, what I hope to achieve after the next 10 minutes is that for all of you to understand the critical role of exercise in falls prevention. And to achieve this, we'll briefly talk about the risk factors that can be modified by exercise. And then, of course, the evidence for exercise, including some research that we've done here at UBC in high-risk older adults. And then to end with an emphasis on what are the key ingredients of exercise to prevent falls. So exercise is obviously an umbrella term, and there's many types. So a key takeaway is what are the key characteristics that you must consider if you do want exercise to prevent falls. So just a very brief review of what Dr. Beauchamp has covered, such that falls themselves are not random events. We know there are key risk factors. And here what I want to highlight is that we typically broadly do categorize the risk factors into two components, such as intrinsic, which are the risk factors that the individual holds. And those include reduced balance, which you heard very clearly, as well as reduced muscle strength, reaction time, as well as components such as vision. And I think perhaps less known is actually cognitive function. So when we think about risk factors, we often do think about, physical functions, but the evidence does strongly suggest that any changes in one's cognitive function also does increase your risk for falls. And then we also want to look at the extrinsic factors, such as the environment. And so this relates to your home environment as well as outdoors. So we heard about how slipping on icy sidewalks contributes to about 9% of falls. And then when you look at the key risk factors, especially within the context of the individual, I think we can all appreciate and agree that exercise can modify most of these, such that exercise can improve your balance, it can improve your muscle strength. And I also just want to highlight that evidence would suggest that exercise actually also improves your cognitive function. And so in many ways, I always call exercise sort of the magic bullet when it comes to falls prevention, because when you think about how exercise might reduce falls, it isn't just one single pathway or one, mechanism. There's multiple ways. And so here I'm just highlighting that, again, exercise can reduce falls by both improving your physical function, but also highlighting that it can also do so by improving cognitive function. And I'll share some research to really highlight this probably less known pathway by which exercise may prevent falls. Now, again, as I mentioned, exercise is a broad term, and by definition, exercise is what movement or physical activity that you engage in to improve specific outcomes. So you go for a run to improve your heart health, lung health. You lift weights to improve your muscle strength. Falls and exercise has been so researched that we actually have very clear evidence as to what types of exercise does reduce falls. And again, Dr. Beauchamp has highlighted this already, but I just want to reiterate this because it is really important. So we know from lots of research and high quality research that when it comes to the type of exercises to reduce falls, it is strength training, functional training. And functional training are exercises such as getting out of a chair, sitting back down and repeating, or practicing stair climbing. So those are what we call functional training exercises, which, as you can imagine, also does target your muscle strength, but in a functional movement way. And of course, balance exercises. And the evidence would suggest is that when you include all these components, so both strength, functional training exercises with balance exercises, there's a high level of certainty that you will reduce falls within the magnitude of 24% to 35%. Tai Chi has also been flagged as a type of exercise that can reduce falls, again, from a magnitude of 19% to 28%. But I do want to highlight when it comes to the level of certainty, it is lower. So it ranges from low to moderate level. And so for today's talk, I will focus more primarily on the evidence for strength training and balance exercises. I think it's also important to highlight what does not reduce falls, in part because, there is a public health effort to generally increase physical activity among all of us, not just older adults, but across all the ages, because we know we're generally more sedentary. And certainly being more active has a lot of health benefits, but increasing physical activity alone does not reduce your falls, nor does engaging in aerobic training per se. So things like, again, walking on a treadmill, going for a bike ride, again, can improve your heart health, can improve your lung health. But in terms of the evidence for falls prevention, there's no effect. Flexibility training or stretches has also not been shown to reduce falls. Again, there's benefits to these types of exercises, but if we're drilling down to whether it would reduce falls when performed alone, the evidence does not support these type of exercises. And then in terms of low certainty, such that, there could be benefit, but really we're just not quite clear on the evidence, that includes strength training alone, dance, and again, walking. And I want to highlight this because, again, sometimes there is a notion that if I go for a walk, that could potentially benefit my risk for falls. And again, I just want to emphasize the evidence would suggest I would have many health benefits, but perhaps have very little for your actual falls reduction. So when it comes to strength and balance exercises, again, in general, we know it can reduce falls upwards of 35%. And I want to drill down to one specific program because it is the most evidence-based, and it's called the Otago Exercise Program, which includes, again, strength training exercises as well as balance training exercises. And originally, it was designed as a home-based exercise program delivered by physical therapists or nurses. And since the initial research, it has evolved whereby it has been delivered and implemented in communities in small groups and by trained instructors versus, healthcare professionals such as physical therapists. But in terms of its delivery, it was originally intended to be delivered at home over 6 months, but just with over 5 visits. So we're not talking about having a physical therapist coming to your home every week or even, every month. So the frequency is such that there's 4 visits in the first 2 months and then 1 booster visit at 6 months. And this particular program has been shown to be consistently effective in reducing falls among older adults. And it's also been shown to be cost effective. And I'll just emphasize again, it is the most evidence-based program. It's endorsed across in multiple jurisdictions in the world, including CDC. So I also want to highlight that the Otago Exercise Program has been shown to be effective at preventing a first fall, so preventing a fall from ever happening again. So usually we're talking about preventing that initial fall among older adults who are otherwise probably doing okay. And then also reducing the chance of falling again among individuals who've already previously fallen. And that's what we call as secondary prevention. So for the Otago Exercise Program, there is robust evidence that it is effective as both a primary and secondary prevention. And so now I'll just share one of the trials we have conducted looking at the Otago Exercise Program in preventing repeat falls among older adults who are recurrent fallers, meaning that they fall multiple times in the 12 months prior to being recruited into our study. So for this particular trial, at the time when we conducted it, there was actually very little evidence to appreciate whether the Otago Exercise Program would be an effective secondary prevention strategy. And so for this study, we recruited 344 older adults, all previously have fallen, and also sought medical attention at our falls prevention clinic. They were randomized either to receive the Otago Exercise Program or usual care. And I'll describe both of those briefly. And so again, in terms of participants, I want just to flag that they were all patients seeking care at our falls prevention clinic, meaning that these are high-risk individuals. They all have fallen and likely have sustained some type of injury because that would be the trigger for them to be referred to our clinic. And they were also recruited based on the fact that they demonstrate a risk for future falls. Again, half were randomized by chance to receive the Otago exercise program. And I really want to emphasize that when it comes to the Otago exercise program, not only does it include the strength training and the balance exercises that has been shown to be effective in reducing falls, but it was also individualized and progressive in nature. And this is an important point, which I'll emphasize more in a couple slides. And then people were also recommended to walk at least twice a week. Individuals who received the Otago exercise program also received usual care. And then the other half of individuals in the study only received usual care. But I want to emphasize this is excellent care. So our falls prevention clinic is still, at the end of the day, a research platform. So we really do ensure that we are delivering best evidence. And so usual care included things that Dr. Beauchamp highlighted as evidence-based approaches for falls prevention. And that included reducing the number of medication, referral to other specialists or other health, allied health professionals, such as occupational therapy for home environment assessment or modification, as well as the universal recommendation for strength training and balance exercises. The only difference is that we didn't actually deliver it to them, but the recommendation was always there. In terms of results, I just really want to highlight that across the board, the 344 participants were really individuals clearly at high risk. They're older, so above 80 years old. They all, on average, experienced at least 3 falls prior to the study, with about a third of them being injured by their falls. They were physically frail, medically complex, meaning that they all had multiple chronic conditions and in many ways physiologically kind of unstable, meaning that, one more event could really trigger quite a adverse outcome for them. On average, they all had mild cognitive impairment. And remember, my emphasis that cognition also is a key risk factor for falls. And not surprisingly, they all had limited mobility. And so what did we find? So perhaps not a surprise, but we actually did find that the Otago exercise program was significant in reducing falls by upwards of 36%. But perhaps what was unexpected is that we also looked at, how did the Otago exercise program reduce falls in this high-risk group of individuals? And surprisingly, we found it wasn't so much improvements in physical function, such as measures of balance or strength, but it actually was related to improved cognitive function that seems to contribute to the significant reduction we saw among those who received the Otago exercise program. And so hence, at this point, I also just want to really highlight that the current framework that we really think about when it comes to the role of exercise in preventing falls, again, is that it has a role certainly in promoting physical function, but it likely also has a significant effect on falls reduction by promoting brain health or cognitive health. Now, I just want to really highlight the key ingredients of exercise. Again, falls prevention is an area that's been so well researched. We can be very exact in understanding what we need to do when it comes to exercise to prevent falls. So first, in terms of the types of exercise, it needs to be strength, functional training, as well as balance exercises. And I want to emphasize physical activity does not equate to exercise. The other piece is that the exercises must be challenging and then progressive over time. And so that does mean that sometimes, depending on the individual, you do require expertise to be able to prescribe exercise that's challenging to an individual who may be physically frail, but still not put them at risk for an actual fall. And the last point I want to highlight is that the evidence suggests that you do need to engage in these specific type of exercises for at least 50 hours. And so that translates to approximately 3 times per week, 1 hour per session for about 4 months. Or if it's twice a week, 1 hour per session, that's for 6 months. And I highlight this because most community-based programs are about 8 to 12 weeks, right? And perhaps twice a week. And I'm not sure about across Canada, but certainly in BC, registering for community programs can be quite the challenge. So the emphasis is that, if you're engaged in a community programming for falls prevention, that's great, but you should also consider doing those exercises on your own at home so that you have sufficient dosing. And the last point I want to highlight is that we really need to understand that one size does not fit all. So even though we understand what are the key ingredients, we also need to consider the individual in terms of their cognitive health, their physical health, and their mental health, because that ultimately will determine their adherence to the exercise recommendations. I mean, we can prescribe and recommend exercise all we want, but if individuals do not actually do the exercises, they're not going to benefit. And so when we think about exercise delivery for falls prevention, we do need to consider for this individual, would individual delivery be more appropriate versus group-based. So for example, for the many people we see at the falls prevention clinic, having them or expecting them to go to a community center and engage in a group-based activity, their level of adoption is very low. And that's why we have no issues during a randomized controlled trial to broadly recommend exercise, because we also know that unless you're actually delivering it to them, the chance of uptake is actually very low. And then again, this relates to whether they could do the exercises at home safely, or can they go out and go to the community center? And of course, the hope is that they would over time transition, right? That they would first engage in at home because they're more frail and have limited mobility. But as they do the exercises, they could actually increase their capacity to then engage at the community level. And then the other piece is that the expertise required of the individual delivering the exercise programming. Again, all of us are different. Some of us do require more guidance when it comes to engaging in certain types of activities. And certainly for older adults who've had a prior fall, they generally are medically complex. And therefore, the level of expertise required to deliver exercise programming for them may be higher. And then the last point is that when it comes to adherence, we should consider incorporating behavioral change techniques, so setting SMART goals, et cetera, for all individuals so that they can increase their probability of adhering to the exercise recommendations. And with that, I will end and just reiterating the learning objectives, and hopefully I've achieved that. Thank you.
Thanks so much. That was very interesting. Answered a couple of my questions that I have. I have a very resistant parent who does not want to exercise. So you touched on one of those major barriers of, even if they know what they should do or need to do, getting them to do it. We need to support them in that. So thank you. Thanks, Teresa. All right, Dr. Sibley, you are up next. So take it away.
Great, thanks so much. You can see my screen okay there?
Are good to go.
Great. Well, thanks so much, everyone. It's great to be here today with such a fantastic audience. And I'm very pleased to be taking the baton from Dr. Beauchamp and Dr. Liu-Ambrose, and also a bit relieved to hear how aligned we are. And it's a bit of a game to be at the end and sort of see what's going to be picked up or not. So I'm going to be talking more specifically about work that we are undertaking to help support implementation of effective fall prevention exercise programs. And I'm very pleased to be presenting on behalf of the AIMS team, which I will be telling you a little bit more about and the work that we are doing. And my goal is to use some of the data that we are learning and gathering to help those of you, particularly who may be offering programs or services, to be thinking about what do we know about getting started and getting these programs going. So as we've heard several times over the course of the talk already, I'm picking up the baton with one of our key messages that exercise as a whole is one of the most consistent ways that we know to reduce falls, particularly in community dwelling older people. We have data, as we've heard, from hundreds of studies and thousands of participants that show us quite convincingly that this is the case. But what we also know is that currently there was data from 2023 showing that just 16% of older Canadians were getting enough of the effective balance exercise that is needed to reduce falls, just 16%. So we know that we have a long way to go in terms of supporting older adults in Canada to be reaching those doses to help them reduce their falls. And as I've already mentioned, we focus in our initiatives on community programming and how that can support fall prevention across the population. And so this is a focus because most Canadians are living in community settings. As we think about how resources within health and social care systems are organized, community programs, particularly those that draw groups in to participate at a center, are quite prevalent and particularly relevant. But we also know that there are a number of challenges associated with program delivery and implementation across Canada right now. And so I'm going to focus on 3 of these as a sort of guiding light for our work. And so the first is that we know that there are inequities in access to community programming for fall prevention exercise across Canada. There's high variability across cities and semi-urban, rural, and remote regions. So your access to a program really depends on where you live right now. And there's a lot we can be doing to increase availability and access to more people across Canada. We also know that amongst the people attending these programs, there is a lack of diversity amongst the older Canadians who are coming. And so the reality is that many of these participants are people who look like me, white women with high socio and economic status. And the data consistently shows that they are the most prevalent participants in these programs. And so in terms of increasing participation, I'm going to be talking more about some of the more specific work we need to be doing to target some of the other underserved groups by these programs. So this could be men, people from different cultural backgrounds, Indigenous populations as well. So a lot we can be doing to think about how to make effective fall prevention exercise for community dwelling people more inclusive and accessible. And we also know from some of our data that many of the programs that are currently being offered are not all meeting the essential conditions, those effective ingredients that Dr. Liu-Ambrose talked about for reducing falls. And there's a lot of reasons for that, which I will get more into, but many programs right now are only able to be offered once or twice a week. They often have, as Dr. Liu-Ambrose talked about, participation restrictions to something like 12 weeks is common. They're not offered year round. And we also know from some of our data that many of them may not be challenging individuals' balance to the level that we need to have that dosing effect. And so when I talk about specifically about implementation, what I'm focused on is the process of integrating effective fall prevention exercise into a new setting. And so I think this is really important to emphasize because right now, I'm actually focused less on what are those key ingredients. We know what they are, but how do we work holistically to help make those happen? And we think about implementation not only at the individual level in terms of participation and behaviors for participating in exercise, but quite a bit at the organizational system level and even at the sort of structural levels. And so a big part of our work is thinking about how do we put these programs and mechanisms in place. And so the reality of thinking about implementing fall prevention exercise that I do want to acknowledge is that it is complex. So regardless of the amount of good data that we have about what to do once we get to offering a program, something like Otego or many other programs that are out there, is that the entire mechanism of implementing a program to support effective fall prevention exercise is complex. And those of us working in the field, we have to acknowledge that, and we embrace the complexity and we work within that. And so trying not to oversimplify anything is a big part of thinking about how we focus on implementation. The other reality is that collaboration is key. Implementing a program is beyond the scope of any individual role involved. And so as someone based in a university setting who does research, I don't implement programs, but I can support them and we can work together to help make that happen. And so for those working in this field and for those supporting others, delivering programs, recognizing that collaborative aspect is really critical as well. And the last part, when we talk about implementation, that I don't think is recognized enough, is that when we're thinking about implementing something, it's actually mostly about the planning phase. And so for those of you working in organizations or communities thinking about getting going, there's a lot of different things that we can be doing to start to support things underway. And so spending time planning for implementation is never time wasted and will result in a better outcome in the end. And so this is what leads us to our AIMS initiative. And so I'm very happy to be part of a team that has been funded to focus on this work for the next several years. And so AIMS is a collaboration of 4 universities across Canada, led by Dr. Danielle Bouchard at the University of New Brunswick, along with myself and Dr. Shilpa Dogra and Dr. Scott Keeler from Ontario Tech University and Dalhousie University, in partnership with over 50 organizations who deliver and support community fall prevention exercise across Canada. And I can see that there's a number of our partners on the webinar today. So hello, and it's great to have you, and please feel free to chime in as well. And so the goal of our AIMS initiative is to support more people, it's exactly what it stands for, to help attract, adapt, implement, and sustain effective fall prevention exercise for community dwelling Canadians across Canada. And so the 4 arms of AIMS recognize, as we've already heard about, that there is not a one-size-fits-all approach to implementing effective fall prevention exercise. And we need targeted solutions and strategies depending on a community's or an organization's individual needs. And so our approach is grounded in all of the great evidence that we've already heard about today, really focusing on how can we support programs to offer challenging balance exercise with a goal of 3 hours per week and, relatively speaking, all year long, because we also know that this exercise needs to be performed continuously. We do that by using implementation evidence and research to help inform our approaches. And as I've already alluded to, thinking about how we are doing all of this with a focus on inclusion, enhancing diversity, and access to these programs. And so I'm going to focus the remainder of my time on some of our early findings and data. And so, as I mentioned, we know that effective fall prevention exercise implementation is multifaceted and complex. And some of our early work has identified almost 300 individual factors that influence effective fall prevention exercise. And so I definitely take the approach that knowing what to do, on the one hand, is the easy part. Enacting that is the challenging component. component. And so again, thinking about the multitude, this is why the complexity of implementation is so important. And so we can divide up the many factors that influence fall prevention exercise implementation into 5 main categories. So things influence implementation at the program level and specific characteristics of how the programs are organized and delivered. Particularly the inner setting of the organization or programs have a huge role in implementation. But it's not just what is happening within the program or within the organization. There are many external factors that influence implementation as well. So no matter where we're implementing a program, there are external outer influences that influence on that. The people involved certainly have much to do with the effectiveness of implementation and these programs. And we need to think about all of them and their individual roles. And then certainly the processes that we use to help implement the programs can have an effect on our success or lack of success in doing those. And so what I'm going to do next is focus a few comments on hopefully some practical recommendations from our data, both in our current phase of AIMS and from our review, on some of the key implementation facilitators for effective fall prevention exercise. And so I've broken these down into 3 key categories. And so thinking about what facilitates this, thinking about program design and considerations and adaptability of programs is key. And so we've already heard about the need for exercise to be challenging and to be progressive, but what that actually looks like is going to be different for every individual who participates in exercise. And so programs need to be able to tailor for different abilities within a reasonable scope, but to be able to offer options for people at multiple different abilities. They also need to be adaptable for different community contexts. So as I talked about, given that we know that most of our participants right now are white women from high socioeconomic settings, we need to be thinking about what can programs be doing to be adaptable to have more relevance and attract different groups coming into these programs. And so these are going to be taking specific targeted actions and potentially adaptations to the programs as well. We always want to keep our key ingredients for effectiveness as we're doing this. So thinking about that challenging piece, thinking about those 3 times a week piece, and thinking about the community, the ongoing nature of exercise needs to be there as well to facilitate that. But within those bounds, what are some of the things that we can be doing to design and adapt our programs to reach as many individuals as possible? I had another point I wanted to say there, but I've lost it. I think it will come back to me, hopefully. One of the other key facilitators that we have heard consistently, both from our previous review and data from our current partners, is that the opportunities for social connection within these programs is a really critical feature that keeps people coming. So I might be delivering the program with a focus on reducing risk of falls, but that may not be the key driver of what attracts someone to one of these programs. And we have heard consistently that people who come value these connections and they don't want to lose that. So ensuring that the social aspect of programming can help support people continuing to participate and come in as well. And lastly, what we also know in terms of adaptability and program design is that we need to be thinking about a mix of participation options for participants. So as we've heard a number of times already, we know that many programs, for a number of very valid reasons, are only able to offer people the opportunity to come in person once or twice a week. And they're often only able to restrict participation to a 12-week period, for example, because wait lists are very long and things like that. But so we feel through AIMS that what programs can be doing is, rather than leaving individual older Canadians on their own to supplement with that, how can we be thinking about within our programs supporting, coaching, and really encouraging those 3 times a week options for getting more people to be doing more exercise. And so one of the things that we're working on in AIMS is how we what are some of the potential tools that programs could be offering to others? So we have partnered with an Australian developer and researchers who have developed the Standing Tall app, which is an effective evidence-based personalized home exercise program. We've also developed a series of YouTube videos with a group in Quebec called Move 50 Plus that offers 12 different levels of balance exercise. You can search Move 50 Plus right now and find those videos. And one of our partner programs, Zoomers in Balance, led by Dr. Bouchard in New Brunswick, offers live online classes across Canada. So again, thinking about what are some of the tools and resources that can help support people across Canada. The second key facilitator I want to focus on is the idea of supporting instructors and leaders. So again, both in our reviews and in our partner data that's coming in right now, the exercise leaders we see very much as the secret sauce in all of these programs, and they're valued by participants in terms of, again, a reason that they keep coming to programs. We know how committed instructors are to doing the best job that they can and being effective in their roles. And so they need support to be at that interface at their most effectiveness, at their greatest effectiveness. So in terms of thinking about this, we have been working in partnership with researchers at McMaster University to help think about how we can better train and support and coach instructors to be monitoring the intensity of balance exercise during classes using a tool called the Balance Intensity Scale. We've also developed an inventory of exercise options that challenge numerous components of balance, and that's freely available as well. So again, sort of building what are all of these potential resources that we need to be doing to supporting instructors to stay as effective as possible. And the last piece that I want to talk about in terms of facilitating implementation is coming back to this idea of collaboration. So again, implementing a program is beyond the role of any given individual. So collaboration is needed both within organizations, and we've actually heard quite a bit in the data about the importance of administrative support to get these programs rolling and underway. Across partners. So again, recognizing the limits of different programs. I think if we could be working together in a more coordinated way, we could be increasing access for more individuals and communities across Canada. And then certainly as well with university researchers and groups like our AIMS initiative. We feel very fortunate that we have both time and funding to help support some of these efforts, and doing so in a rigorous and evaluative way, so that when our AIMS time is over, that we can leave our community with resources and a good legacy. So with that, I will just close by saying that we still have opportunities for engaging with AIMS. And so if you are interested either in implementing an effective program in your community or in your organization, if you don't have one, or if you already offer a program and are looking perhaps to enrich or adapt that program, we are very interested in connecting to learn more about you and your needs are. And so I leave you with our email address here. Please feel free to reach out at any time. And so with that, I will stop sharing and looking forward to some discussion. Thank you.
Thanks so much. Thanks to all three of you for wonderful presentations and ones that fit so nicely together. I know you coordinated. Thank you. That really shows and very much helps. We have I think 10 or 11 questions, so I want to for the next 15 minutes or so go through those questions, and I'll try to direct it to the right presenter, but it certainly each question is open to any of you to respond to. The first one is about the Otago exercise program, and the question is, what does the booster visit consist of? Is it increasing the intensity repetition of the Otago exercise program? That
Yeah, maybe I can take
Teresa,
that.
yeah.
Yeah, so the booster session is really like a reassessment, such that it would be looking at how they're doing in terms of their balance and strength and functional movements as well. And then the intent is to then progress if appropriate. It may not be all the exercises, but certainly assuming people have done the exercises, some subset of them. The Otago manual actually has all the progression as well. So there's a number of exercises and there's like very clear progression across the board for each exercise as well that the physio or whoever is delivering the program can mark down for the individual.
Great. So we have a couple, I think, Teresa, that are directed at your information. So the question is, exercise does improve cognitive functioning, but is there any cutoff, like MOCA
MoCA?
13 dash
Yeah.
13/30 as an exclusion?
Yeah, so I mean, in our own study, we did exclude people with frank dementia. So just to say, like the RCT that I presented, people definitely had mild cognitive impairment, if not early dementia, early stages, sorry. But if you look at the literature broadly, in terms of among individuals living with dementia, exercise does seem to have some degree of benefit. Although those studies, we don't tend to focus on cognition as much as their behavior and their quality of life, because at that point, some of the behavior changes is actually more critical in terms of how they manage or how their care providers manage.
Okay. And I think this builds on that last question, and your answer is, how was cognition being measured?
Sure. Yeah. So we did a screen based on global standardized measures such as the mini mental state as well as the MoCA, the Montreal Cognitive Assessment. But we also did a brief but comprehensive cognitive battery as well that focused on memory and executive functions. I didn't have a lot of time to go into the slides, but what we did find is that improved executive functions was the sort of the mechanistic pathway it would appear that contributed to false reduction in the Otago group, which does align with the literature broadly.
Thanks. There's a question about, what is the best tool available to assess risk for falls? And I will put it out there. Whoever wants to answer that question.
I'm happy to take that one. There is no single best tool, unfortunately, that's endorsed for screening for risk of falls. And we've been in our group trying to find one that meets our that has, good accuracy and is consistent across different populations. We have not found that yet, which is why I mentioned those three screening questions endorsed by the World Falls guidelines. So have you fallen in the past year? Do you feel unsteady when standing or walking? And the third one is, do you have concerns about falling? So just those three questions do a pretty good job at identifying people who have an increased risk of falls.
And if
I don't know if
may,
Teresa, yeah.
Yeah, and I think just if we stick with sort of the interview process, because again, those are quick generally, is that if they do report a fall, it is based on the evidence and what we see in clinic to ask whether it was indoor in their own homes, and of course, if they're injurious. So if they're in their own home and injurious, that usually it raises the risk for a subsequent fall versus, let's say, they fell because their dog pulled them over while they're walking. So falls, as a definition, are similar, but then when you get into the nuances, it does then start separating who you're more concerned about.
That was actually one of my questions was like that fall definition that we started with. Do you think it needs to be changed or more nuance put in it? I'm thinking about, the folks who stumble and sort of, well, I just went down on one knee. That's not really a fall.
Mm.
Do we have to, is the definition adequate?
I mean, I do think we want to capture those stumbles, even if they don't result in injuries, because the next one could, right? So even if people do, um, don't have a major injury or it's a less serious fall, it's still really important that we identify people that are more prone to um, those kinds of falls or stumbles or trips or slips because those that does require a balanced reaction, and that is something we can train to improve for the next time. So I'm not sure. I'm not sure we need to change the definition. I think what we do need to do is categorize, make sure in all of our research studies and when we're talking to patients and clients, just as Dr. Liu-Ambrose was just saying, we need to understand what were the circumstances around that. So I'm hiking and I lose my balance and I slip and I land on my knee versus I'm just doing something in the home and leaning forward to try and pick something off the floor, because that those imply very different pathways that might be causing the fall. So I think we do need to do a better job at characterizing falls that occur in our patients and in our research studies so that we can and that might actually help us to better identify better screening tools that predict certain kinds of falls.
Hmm. Yes. Yeah. And like more of a spectrum. Yeah. Um, Catherine, there is a question about the exercise needs when we talk about exercise needing to be 3 times a week for 4 months or 2 times a week for 6 months. What happens after the 4 months or 6 months if individuals cease to do those exercise programs? I'm going to guess they kind of regress
Yeah.
back into where they were before. But
Great question. Yeah, generally with exercise, the message is use it or lose it. And so the data around this 4 month or 6 month thing sort of comes specifically from the trials and the periods that they studied. And some of the additional updates also talk about exercise needing to be done continuously. So this is exactly one of the things that we're working on AIMS is how do we find, I think the messaging needs to be, and if we look at something like the current Canadian 24-hour movement guidelines, it's not about doing this type of exercise for a fixed period. It's about building these into our life as a whole. And yeah, I'll not digress there. So thinking about, yeah, how can we get more people exercising consistently throughout the year on a long-term basis, I think is really important. And that's certainly how we are trying to take our approach in AIMS as well.
great. There's a question about long-term care facilities, and are the falls occurring in those facilities included in the statistic 1 in 3 older adults fall each year?
No, the 1 in 3 is for community dwelling older adults.
Is there separate data on long-term care
Yeah.
facility and hospital? I guess, would they be separate?
Yeah, so I answered a question around that in the chat. So the talk today, we were all really focused on community living older adults in this talk, but it is in long-term care and in people with dementia. I think that was the other
Yeah.
population that was mentioned. There's maybe less evidence overall. But there is evidence that supports multifactorial fall interventions. And exercise definitely still plays a role where possible. So when it's individualized and tailored and has the appropriate supports, it can be effective. It's not, I'm not sure if anyone else has anything to add, and about that. Teresa, maybe.
Teresa, Kathryn.
Yeah, I think falls in long-term care is a much harder. It's a tough environment, I think, to put it politely. Anyone who's had a family member in long-term care, usually they will notify you if your loved one has had a fall, and those notifications are very frequent. Yeah, I'm not sure how to expand more. I mean, because in some ways, when we think about things like exercise, it could potentially be beneficial for some individuals or residents of long-term care. I mean, they're very much in their beds a lot of the time.
Yeah, and one of the questions talks about, the assisted living, long-term care, day programs. Oftentimes they want people to do exercises sitting down. And
Seated, yeah.
personally, I've experienced the limitations of liability and a fear of them
Yeah.
falling restricts
Mhm.
what the exercise, when you go into a hospital, it's basically like you say, they're in bed most of the time. So, that just limits and goes back to Kate, what you were saying about, use it or lose it, how quickly they lose, individuals lose capabilities and function while they're, every day in bed. So,
And that's where too, like a lot of the other kinds of fall prevention interventions that we know can work, making sure there are as little hazards as possible around the bed so that when patients do get up, there's no tripping hazards, medication review for any medications that might be causing dizziness or might be having interactions is more important. Orthostatic hypertension, like treating that if that's an issue, in long-term care, making sure people have the correct mobility aids and they know how to use them properly. So some of the other kinds of interventions that we can do might play maybe more of a role. But then, as much exercise that can be done is still important within the constraints of safety, obviously.
Yeah, for me, I think it's just that the context of both falling and implementing interventions in long-term care is very different, right, than in community dwelling folks and in community programming. And so you almost have to go back to the beginning. And there is some implementation research around fall prevention in long-term care. So we can draw on that a bit. But if I think about and so I see some of the questions coming in and just sort of acknowledge it. The implementation challenges are real and those are valid, right? And if you're understaffed and it is not safe to be offering challenging balance exercise, that's okay. Sitting things are okay for physical activity, for social engagement, for all of these good other things we've talked about. It's not going to reduce your falls. And so let's just sort of put those things into different piles. And it's not, and kind of sort of that's how I typically think about it, as these are all good and fine things for other things. We're just not going to sort of draw that line to reducing our risk of falls. We're going to need to think about other things in that way.
thanks. There's a lot of questions about the Otago program that we wanted to let people know that there's lots of links that we're going to be able to send out post webinar that will probably answer some of those questions. So I don't think we're going to be able to get to all of those, but we have noted them, and we will endeavor to get you answers and links to that. There's a question about, would it be more beneficial to have more objective scoring process than subjective survey based on observation and client responses? I kind of think you need a bit of both, but I'll open it up. Kate did, or Teresa or Marla, did you want to take that?
Um, But in terms of assessing for risk
Yeah.
or monitoring, yeah. So, I mean, there are mobility screening tools that are often advocated for screening for fall risks, and it's certainly useful to use those tools to identify deficits. So something like a timed up and go, where you time a person getting out of a chair, walking 3 meters, turning around, coming back, and sitting down, or someone's usual gait speed over 4 meters. Those are sort of two commonly advocated for uh, tests of mobility that do they do predict falls. Low performance on those tests can predict falls, but in terms of identifying who will fall, they have limited accuracy there. I think those tools I think can and should be used to at the beginning of a program to look at response, like to look at, just is physical function or mobility improving after an exercise-based intervention. But there's not one sort of great cutoff on those tests that really accurately identifies people who will fall. And we've tested this kind of empirically in our lab, like we've evaluated using those tests as along with the World Falls Guidelines, and we haven't really found one test to sort of be better than than another, or one test to have sort of sufficient discriminative accuracy to really identify with certainty this person has an 80% chance of falling. We're not there yet. And I don't know if others have things to add.
Well, I think it's both, I think, because there is a disconnect sometimes. So we've looked at this before where you could have somebody who performs really badly on their balance, like objectively, and then you ask them about their self-efficacy related to falls or to their balance, and it doesn't match. And we know sometimes some of the falls, I mean, again, is a loss of balance, but the person also does make a decision whether they put themselves at risk or not. So there is that component that is harder to quantify. Is that decision in that moment, like should I decide to step on a stool and reach for the top of the fridge when my balance is poor? Should I hold on to somebody or have someone support me in that moment? So those scenarios are not captured solely by our objective measures, right? Nor are they captured solely by our subjective like responses. So I do think it's both. And then again, we have noted in our research that sometimes there's like a very strong disconnect.
Yeah.
And potentially gender differences as well. That's what we've noted.
Okay. That's great. We are at time. It flew by. Lots of great questions. We'll capture the other questions. We'll try to get answers and or links to the group that is asking and the rest of the participants because they'll probably want to know the answers as well. Thank you so much. Thank you, Teresa, Marla, Kate. This has been wonderful. And from the number of people who attended, it is a very in-demand topic to hear about and to ask questions about. So thank you. For everyone who is still on the line as we end the webinar, you will get an evaluation. So just a reminder, if you could please fill that out, that would be wonderful. And thanks everybody for joining us and have a great rest of your day. Thanks everybody.
Thank you.
Thanks. Take care.